Pleural effusion none. Understanding the pathophysiology of pleural effusion. 1. Key concept. Abnormal accumulation of fluid in the pleural space, the area between the visceral pleura, covering the lungs, and the parietal pleura, lining the chest wall. 2. Simplified explanation. Think of the pleura as a sac around the lungs. 2. In a pleural effusion, this sac fills with too much fluid. 3. Mnemonic. Pleura. For key aspects of pleural effusion: pleural space, liquid accumulation; excessive, abnormal amount of fluid, usually secondary to another condition: restricted lung expansion, altered lung function. 4. Key features. Pleural space normally contains a thin layer of fluid that lubricates the lung surfaces and allows for smooth breathing. Fluid accumulation. Excess fluid collects in the pleural space, which can be due to multiple underlying causes. Types of fluid. Transudate, protein-poor fluid, often due to increased hydrostatic pressure or decreased oncotic pressure, common in heart failure. Exudate, protein-rich fluid, often due to inflammation, infection, or malignancy. Empyema, pus in the pleural space. Compression of the lungs can lead to impaired lung function and reduced gas exchange. 5. Main causes. Heart failure. Increased hydrostatic pressure leads to transudative effusion. Pneumonia. Inflammation and infection in the lungs can cause exudative effusion or empyema. Cancer. Malignant tumors can cause exudative effusions through inflammation or direct involvement of the pleura. Pulmonary embolism can cause both transudative and exudative effusions. Hypoalbuminemia, low protein levels in the blood due to malnutrition, liver disease, or kidney disease, which can cause decreased oncotic pressure, leading to transudative effusions. Kidney disease. Fluid overload and protein loss can lead to transudative effusions. Liver disease, cirrhosis, fluid overload, low albumin levels, and portal hypertension can lead to transudative effusions. Autoimmune disorders, such as lupus and rheumatoid arthritis, may cause exudative effusions. Trauma. Chest injuries can cause exudative effusions. Medications. Certain medications can lead to pleural effusions. Idiopathic. In some cases, the cause is unknown. 2. Clinical manifestations of pleural effusion. 1. Key idea. Symptoms vary based on size of the effusion and the underlying cause. 2. Mnemonic for pleural effusion symptoms, DCDP. Dyspnea, shortness of breath, especially with exertion or while lying down, orthopnea. Chest pain, pleuritic, sharp, worsens with breathing, or chest discomfort. Decreased breath sounds on the affected side. Pleuritic cough. 3. Additional signs. Dullness to percussion on the affected side of the chest. Reduced or absent tactile phremitis, vibrations felt on the chest when speaking. Asymmetrical chest expansion. Pleural friction rub, a coarse grating sound that is caused by inflamed pleural surfaces rubbing together. 3. Diagnosis of pleural effusion. 1. Key idea. Diagnosis involves imaging and often a thoracentesis, removal of pleural fluid for testing, to determine the underlying cause. 2. Mnemonic for diagnosis, ITE. Imaging, chest X-ray, can detect fluid accumulation in the pleural space. CT scan, more detailed imaging to assess for underlying lung disease or tumors. Ultrasound, can be used to visualize fluid and guide thoracentesis. Thoracentesis, removal of fluid from the pleural space for analysis. Examination of the pleural fluid, protein levels, to differentiate transudates and exudates, Light's criteria. Cell count, to assess for infection or inflammation. Culture, to identify infection. Cytology, to evaluate for malignancy. IV, management of pleural effusion. 1. A key idea. Treatment focuses on addressing the underlying cause and relieving symptoms. 2. Mnemonic for management, ADT. Address underlying condition, such as treatment of heart failure, malignancy, infection, etc. Drain the fluid, thoracentesis. Can be diagnostic and therapeutic for removal of large amounts of fluid, or for symptomatic relief. Thoracostomy and pleurodesis, in cases of recurrent pleural effusions. Placement of a chest tube to drain fluid and then pleurodesis, which is done to cause the pleural linings to scar together, to prevent the fluid from reaccumulating. 3. Additional treatments: diuretics for fluid overload, oxygen therapy for hypoxia, Antibiotics for pleural infections, empyema. Pain management. V. Potential complications of pleural effusion. 1. Mnemonic, IRES. Infections such as empyema, respiratory failure, hypoxia, respiratory distress. And entrapment, inability of the lung to expand properly due to scarring of the pleural space. Septic shock, from an empyema or another underlying condition. 2. Additional complications, recurrence of effusion. Lung atelectasis. Fibrothorax, scarring of the pleura. Simplified explanation. 1. Fluid accumulation. Excess fluid builds up in the pleural space around the lungs. 2. Lung compression. The fluid compresses the lungs, making it harder to breathe. 3. Symptoms develop: shortness of breath, chest pain, and cough result. 4. Underlying cause. The cause of the effusion needs to be determined to direct therapy. Professor Hammer's advice for learning pleural effusion. 1. Understand the pleural space. It's normally a space that lubricates the lungs. 2. Differentiate transudates versus exudates. The type of fluid is key to diagnosis. 3. Recognize the symptoms. Dyspnea, pleuritic chest pain, and cough are key symptoms. 4. Understand the tests. Imaging and thoracentesis, fluid analysis, are important for diagnosis. 5. Focus on management. Treating the underlying cause and drainage of the effusion is essential. In summary, pleural effusion is a condition caused by abnormal fluid accumulation in the pleural space. Treatment is aimed at identifying and treating the underlying cause of the effusion, and also providing symptomatic relief by draining fluid from the chest.